Thank you very much for the kind introduction. I just want to also take this opportunity to thank VSRNM as well as AOSOR for the kind opportunity to share some experience with MRI vessel wall imaging that we have done in Singapore General Hospital. So if we do literature search on the topic right now, you'll find that the publications mostly peaked around 2021, and we're now on the downslope. That's to say that the MRI vessel wall, generally in most parts of the world, is starting to mature, and its clinical applications are fairly underway right now. In SGH, we started vessel wall imaging almost 10 years now, back in 2017. And right now, we do probably about, for various indications, mainly for problem solving, around 150 cases a year. So just a brief outline, I'm just going to talk about some imaging techniques, the clinical applications, and the experience that we've gained so far, as well as the pitfalls of vessel wall imaging to watch out for. So imaging technique. We are imaging intracranial vessels, and specifically the vessel walls, which are extremely tiny, averaging about, sub 0.5 millimeter in thickness. So it's actually beyond the normal resolution of most available imaging voxels. So high magnetic strength is required. So 3T is usually the go-to. So the key to be able to see the vessel wall is to nullify the flow signal within the lumen, as well as the CSF surrounding it, so that it highlights the signal that's given off by the wall. In the beginning of vessel wall imaging, I think there is a discussion between 2D versus 3D acquisition. I think this is more or less settled. Of course, we know 2D acquisition. I think it needs clarification here when I say longer scan time for 2D. That means 2D acquisition itself is definitely quicker than 3D. But because of the intracranial vessels making a lot of turns in the head, you are bound and obliged to acquire in orthogonal views. So if you acquire 3 times the 2D, in terms of axial, coronal, as well as sagittal, it's going to be much more time than just a 3D acquisition. While it provides a lot of in-plane resolution, it is prone to volume averaging artifacts. And when you are imaging such a small structure, that can be problematic for your interpretation. So this is the SGH protocol, just to show that 4 general sequences: T1, pre and post contrast, time of flight, as well as a T2. So all in all, about 45 minutes we should be able to acquire. And a slightly truncated one for an aneurysm protocol. Usually we don't do the T2. And also you can see that the matrix is generally smaller, as well as our slice thickness is just a little bit larger, which is 0.7 compared to 0.5. Clinical applications. I think I'm just going to focus the discussion mostly on ICAD, which is intracranial atherosclerotic disease, versus moya, which I think helps our vascular neurosurgeons as well as the interventional neuroradiologists a lot in terms of counseling patients for therapy. Also to look at dissection, which previously, probably I'd say 5 to 10 years ago, people don't talk about intracranial dissections very much. A lot of these cases have been wrongfully classified into just ICAD mostly, and more rarely vasculitis. And then just a few words about aneurysm and its utility for risk prediction. So ICAD, I think generally the established features are that there are classical locations, number one. Number two, the lesion is mostly eccentric. It's on one side of the vessel wall rather than involving the entire vessel wall. One prominent feature is that of positive remodeling. It enlarges the vessel size most of the time, especially in its early stages. At its late stages, it can undergo negative remodeling, but predominantly when the patients are symptomatic, you do see positive remodeling more. And with vessel wall, you can see the plaque components, and I will elaborate a little bit more later. So as you can see on outline on the slide here, this is a T1 post-contrast weighted imaging. What is interesting is that a lot of times, especially in the large vessels, you can see the hyperintense fibrous cap, which we call it juxtaluminal, which means it's the part that's closest to the still patent vessel lumen. This is usually T2 bright as well, if the resolution of the T2 is large enough to see it. Deep to it, you see areas that are non-enhancing, and generally these would represent the fat-rich necrotic core that doesn't take up contrast. Sometimes, very rarely, you can see symptomatic plaques. When there is hemorrhage within the plaque, then you will see intrinsic T1 hyperintensity, but that's not very common. And as we've discussed, there are some classical locations, and typically, I think, I was supposed to highlight the classical locations generally are in the terminal ICAs, M1, as well as the basilar trunk, taking, I think, upwards of 60 to 70% of most ICAT and symptomatic lesions. While most of them are eccentric, a small percentage can be concentric as you move towards the smaller and smaller vessels. Now, this is to highlight how it looks like generally. This is a segment of the terminal ICA or the supraclinoid ICA, eccentric in location, and you can see on post-contrast, there is the classical enhancing fibrous cap, and also demonstrating just a hint of T2 hyperintensity. Deep to it, you don't see enhancement, and this is classical of the lipid-rich necrotic core that we talked about. Now, this is another view of a different vessel, and this one demonstrates positive remodeling quite clearly. You can see that the vessel enlarges outwards and makes the entire caliber of the vessel larger than its native caliber. So as you move on to smaller caliber vessels, like this one is in the MCA M1, M2 junction, you can see how spectacularly it actually modifies the vessel. The vessel is actually grossly enlarged, and in some cases, when it's a little bit smaller, the fibrous cap can encircle the entire lumen, as it shows enhancement here. And of course, if you image it not transaxially to the vessel, but in this case, sagittal to it, you can see the various components as well. Apologies. Like for example, in this case, the enhancing fibrous plaque as well as the non-enhancing deeper component. We want to differentiate this from moya-moya disease because for our vascular neurosurgeons who do bypass, moya-moya has very strong evidence for revascularization through EC-IC bypass. Whereas in patients with sternal-occlusive diseases intracranially that's due to ICAD, the trials have mostly been negative. So bypass cannot be offered as readily upfront. Moya-moya is basically a sternal-occlusive process that involves very classical segments as well, typically of the terminal ICA and contiguously involving the M1 as well as the A1 segments of the anterior and middle cerebral arteries. So it causes the vessel to shrink in size, and one of the most remarkable features is negative remodeling, which is counter to that of ICAD. Predominantly in East Asians and females, and generally in two peaks. Pediatric age group, which typically presents with ischemic symptoms, and the next one in a young adult to middle age, when they can also present with hemorrhagic symptoms from the friable collaterals. So as we see here, negative remodeling, I would say, for vessel wall imaging wise, it's probably the most striking appearance. The earlier publications for moya-moya, before we started doing vessel wall imaging, a lot of discussion centers on it not showing contrast enhancement. But after having many years of experience with moya-moya, what we found is that that's not essentially true. In fact, a lot of patients, when they first come with symptoms of occlusion, they actually tend to show pretty concentric type of enhancement. And this is a classical appearance, pruning of the MCA tree bilaterally, and development of very robust collaterals at the sites of the lenticulostriate arteries. Now, as in this case, the patient presented with, if I remember correctly, it's a right hemispheric syndrome. There is some enhancement, and more we are seeing that in patients with symptoms, they actually do show up with enhancement. This one is to show how remarkable the negative remodeling can be when you compare right to left. And also unilateral moya-moya is beginning to be more and more recognized as an entity, maybe because we are picking up more and more of these patients earlier. Some of them do progress to become bilateral involvement, but unilateral moya-moya now, on its own, if you see the classical features, is sufficient to make a diagnosis. And it's just to, this is just to point out the difference in a patient with moya moya only on the right side, you can see the remarkable difference in terms of vessel caliber and the negative remodeling that it has caused on the right side. Now, it's important, for example, if you see another case that has a similar MRA appearance, is it always unilateral moya moya? This is when vessel wall imaging will be helpful. And if you see this appearance, it's quite classical for ICAT. So that is to say, in this patient, you wouldn't offer bypass upfront because the trials have all been negative. Arterial dissection. I think a lot of times when we don't have resolution, you see a focal narrowing of the vessel. Most of the time, the patients have a bit of cardiovascular risk factors. We confine the patient to a diagnosis of ICAT. But now with high-resolution vessel wall imaging, we can actually say that it's dissection and it's not ICAT. The giveaway usually is the double lumen, although it's not always easy to see. Sometimes you can see the intramural hematoma, which will initially appear as a T1 hyperintense on T1 imaging. Most commonly involves the V4 vertebral arteries, followed by M1 MCA, and sometimes the supraclinoid ICA. This is an example confirmed on catheter angiography as well. You can see the flap projecting into the lumen of the vessel. And similarly, it's the same lesion that's demonstrated on catheter angiography. Another case, 41-year-old, left ataxic hemiparesis with right lenticular striae region infarct and sternoclusive lesion in the right distal M1. If we just go on this, most of the time it will be given a diagnosis of ICAT, right? But if you go to vessel wall, the lesion just proximal to the maximal stenosis, this is what we see. Some T1 post-contrast enhancement, which can look like ICAT, and also a bit of eccentric thickening. But if we go on, this slide basically clinches the diagnosis, the presence of the double lumen. Nothing else gives you this appearance except for dissection. Now, in less frequency will be the vasculitis, right? They can be inflammatory or infective, and typically the key features are that of concentric wall thickening and enhancement. Excuse me. And what usually is very convincing is the presence of periadventitial involvement. That is the soft tissue that is surrounding the vessel wall that can also give rise to a lot of inflammatory change and enhancement. And depending on the type of vasculitis, it can involve all segments of the vascular tree. In this patient, we see the classical beaded appearance of the left M1, as well as the PCA segment, also on the same side. And this is the imaging on vessel wall. Concentric type enhancement, as well as some irregular wall thickening. And as we go a little bit more distal in the PCA, a lot of periadventitial enhancement. Another patient with autoimmune disease, antiphospholipid syndrome, presenting with left-sided weakness. And again, we see a focal stenosis in the right M1. Again, if we look at the post-contrast enhancement, there is just a little bit more than the vessel wall itself that's being involved. The soft tissue around it also is enhancing, which is the giveaway for this case, why we call it a vasculitis. RCVS, I think our part of the world is not so common because for the risk factors, it's generally drug use. I think in Europe as well, in the US, when I was doing my fellowship in France, we do see a lot of patients with RCVS. The key here is reversibility, but the problem is on the initial onset, you wouldn't know because you need the time frame that have elapsed to be able to tell that, on follow-up, the lesions go away. Generally, they cause multifocal stenosis, can cause severe headaches, and in some instances, even causes SAH. So if we look at this one here, concentric enhancement of the two ACA vessels in this area, and higher up, you do see very subtle enhancement after giving contrast, right? But crucially, on follow-up, after 3 months, everything went away. The stenosis as well as the enhancement. So in this article here actually depicts that about up to half of them display vessel wall enhancement, and a good portion of them actually retains the enhancement after the stenosis is reversed. So the distinction is important because the treatment is also different. For vasculitis, you have to treat the underlying cause, whereas for RCVS, typically we treat them mostly only with calcium channel blockers and watchful waiting after that. Now, moving on to aneurysms, we use vessel wall imaging mainly for problem solving and risk stratification. Apologize for my voice. So in the case of multiple aneurysms and SAH, one of the utilities of vessel wall is to see whether or not the vessel wall of the aneurysm enhances. That gives rise to the clue that that may be the symptomatic aneurysm. Although it's not always the case. Sometimes it's quite clear, like in this case, there is already a hematoma next to the aneurysm, which tells you that this is probably the one that is ruptured, but on top of that, you also have enhancement, compared to the basilar top aneurysm that did not enhance. The utility, we think, is more for unruptured aneurysms, because if you initially image an unruptured aneurysm and it does not demonstrate vessel wall enhancement, the negative predictive value that it will stay stable is actually quite high, upwards of 90%. When you have enhancement, however, it's a bit of you're none the wiser, right? You still have to typically follow up these patients. So this is how it looks like when there is no enhancement in this MCA bifurcation aneurysm, and when there is enhancement. So this aneurysm has a daughter sac at its apex, shows up with very avid enhancement post-contrast. It's very important to talk about pitfalls, because if you don't know the pitfalls, you may misinterpret the things that you see. The long acquisition time and the high resolution of vessel wall imaging makes it difficult when there are motion artifacts. That's a given. The rest of them, I will go through them one by one real quick. So flow-related artifacts. We know that when blood flows in a vessel, the velocity is different. The one in the center flows the fastest. Those around the vessel wall, closest to the vessel wall, flows slower. So because of this difference in flow velocity, those that are closer to the vessel wall can actually give off some mild enhancement sometimes. So it's very important to know this. In venous structures, you can see down in C and D, veins generally flow a bit slower. You typically see the normal appearance, we so-called, of venous enhancement, which is actually given off by slow laminar flow of the part of the blood that is closest to the vessel wall. Vasa vasorum is a normal structure. Essentially, nutrient vessels that supply the vessel wall, and these are normal structures, normal perivascular enhancement that you can see. Thank you very much. Involving the vertebral arteries as they cross into the foramen magnum up to 1.3 centimeters, as you can see here. As well as for the ICA as it crosses the dural ring, about 2 millimeters of that can also appear with normal enhancement. If you intervene in the vessel, like after a thrombectomy, you pull a stent retriever through to remove a clot, you can also see typical enhancement, which makes it very difficult to draw any conclusions once you have actually intervened on the vessel. As you can see here, after thrombectomy of the M1, this patient underwent a vessel wall, and the entire segment shows enhancement, likely related to the thrombectomy itself. And certain aneurysm locations make it difficult. For example, if the aneurysm arises from the cavernous segment or is right next to the pituitary gland, after you give contrast, these physiological structures demonstrate enhancement as well. So you can't actually differentiate that from actual aneurysmal wall enhancement. So certain locations are a little bit difficult to draw any conclusions. So key take-home points, basically, we use it for problem solving. Steno-occlusive disease to differentiate ICAT versus moya-moya, which have prognostic factors, as well as to guide treatment offerings. Vasculitis and RCVS, obviously, because the medications are different. And for aneurysms, main utility is the lack of vessel enhancement in unruptured aneurysms. And of course, we have to understand the pitfalls to avoid errors in interpretation. Just a quick slide on the horizon. 7T, unfortunately, is not in a very democratized use because of its cost. But you can see, actually, we see a lot more detail in the same cases that are scanned with 3T and 7T. In this case, in CNS vasculitis. And also in this case of ICAT. You see a lot more detail on the 7T, but the question, of course, is it necessary? Right? I think if it's available, it's definitely nice to have, but unfortunately, the cost is very, very prohibitive. Thank you very much.